So all studies have to go through a vetting process before we're allowed to start the study. And that process, we have to write up a document that explains what we're doing, how we're going to keep our participants safe, how we're going to keep their information confidential, and any risks that might be involved with that. We take that document and we give it to what's called the Institutional Review Board, or IRB, here at Rockhurst. And that's a group of fellow professors who look it over and they see if there might be any potential problems that we as researchers can't see in advance. And so they'll come back with comments to us and they'll say, have you thought about this? You might want to try this, or we don't think you should do this because it's unsafe, or whatever. And then we modify the study based on their comments, or we tell them, no, we think this is okay because this, but we basically have to explain ourselves for why we're doing something that could potentially anyway be harmful. Then once everybody agrees, we get approved and we're allowed to perform the study after that. So I'm really passionate about research in general, but also getting students involved in research. Scientific research is what ultimately informs clinical practice. So, a clinician wants to know if what they're doing is effective. And the scientist, with the research is kind of the person, behind the curtain saying, yes, what you're doing works. And so they need that to be able to, to know they're not just doing something for the sake of doing something. They want to know what they're doing is effective. I enjoy personally getting students involved in that research process, just because it's in my opinion, it's real science. You're not just sitting, reading it in a book or listening to it in a lecture. You're actually doing the science, and you're able to see not only doing the science, but you're also able to see the little problems that come up along the way and how people process through those problems and troubleshoot those problems, so that they can get the best possible study that they can have, so that they can inform the clinician. So just in any general scientific study, you want to get as many people as you possibly can. Obviously, we want people who have this condition, so that eliminates a certain part of the population. So we have to screen for, the person has to have sustained an ankle sprain initially, and then they need to have developed this condition, this functional ankle instability. And that's about 40% of people who have that initial sprain. So already we're kind of cutting down, the people who we can test. We're also, because we're doing this yoga intervention, we're also looking for people who have never done yoga before. We're looking for, novices, so that the yoga will have the most possible effect. So again, ideally we get as many people as we possibly can, but we have to have what are called inclusion and exclusion criteria to narrow down to look at this specific condition and the effect of this specific intervention. Kind of a rule of thumb is you want to get 10 people for every measure, for every dependent variable that you're measuring. And so you need to look at your study and kind of decide what are the really important things that you want to measure, so that you don't end up having to recruit 1,000 people or whatever. So I kind of do an initial what's called pre-screening. I'll put out the call for subjects in my classes or whatever, and I'll ask people if they sprain their ankle, and then I'll go and I'll ask them, okay, so you sprained your ankle, but did it lead to this condition, this functional ankle instability? And so I'll describe it a little bit, and to see if they're still if they still fit this criteria. I'll ask them, if they do yoga regularly, and again, if they meet these pre-screening conditions, then I'll actually bring them into the lab and perform what's called informed consent. So we talk to them about what the study involves, we talk to them about the possible risks, we assure them that their confidentiality is going to be maintained throughout the course of the study, things like that. If they agree, then they sign what's called an informed consent form, and then we begin to perform the pretest. We have them fill out some questionnaires about their health history, how many times they've sprained their ankle, what particular symptoms of functional ankle instability do they have. So they fill that out. We have them fill out a specific questionnaire to measure what's called their perceived instability. So how unstable do they think that they are? And that's a validated questionnaire. It's about 9 questions, and they answer that for both ankles. Looking at, do they have pain when they walk? Do they have pain when they run? Do they have pain when they hop, when they walk on an unstable surface, things like that. Then we take some measurements. We measure what's called their ankle range of motion, which is how far their ankle can move in all the different planes of motion. And then we perform a test of what's called their proprioception, which is, so basically what I do is I put their foot in a certain position, and then I have them kind of move their foot around, and then I have them try and recreate that same position. What people have found in the past is that people who have functional ankle instability can't do that as well as healthy people. So if I tell them to, to put their foot in this position, maybe they end up putting their foot in this position. And that's honestly one of the reasons why we think people with functional ankle instability sprain their ankle more often, is because when a healthy person thinks they're putting their foot down like this, somebody with functional ankle instability might think they're putting their foot down like this, but they're actually putting it down like this, and that can cause them to roll over more quickly on their ankle. So we test that to see how well they can recreate those joint angle positions. And then we have them perform static stability tests. We have them balance on one foot. We have them do that eyes open and eyes closed to see how well they're able to maintain that single leg balance pose. And then lastly, we move on to the most difficult part, which is the dynamic stability task, which is the single leg drop landing. So we have them stand on a 30-centimeter platform, and we have them step off to the side of that platform onto one foot, landing on one foot and maintaining their balance as quickly as they possibly can on that one foot. So we have them do all that. That takes 45 minutes to an hour. And then we describe the yoga intervention to them. So the yoga intervention is 6 weeks of 2 yoga sessions a week. Each session is about 45 minutes. So we give them access to YouTube videos. They go home, they do that. They come back after the 6 weeks, and we do the post-test, and basically that's exactly what we did in the pre-test to see how those measures have changed over the 6 weeks. So I became interested in research. So it's particularly exercise science research. I was very involved in sports when I was a kid, like a lot of people, and I was also very good in math. And I don't know, sometimes those two things kind of run in separate tracks. It's kind of interesting to me. But I was involved in kind of both worlds, and what I began to see was that there was math in sports, that you could throw a ball a certain distance, or lift a certain amount of weight, or run a certain distance in a certain amount of time, or something like that. And so I started to notice in my own athletic experiences, I started to notice kind of trends in the numbers, if you will. So why was I lifting more weight after a certain training program, or why was I able to run faster after running a certain training program? And so the trends became interesting to me, and how those trends are affected by, for example, different training programs or fatigue or things like that. I honestly didn't know the field of exercise science existed until I was probably junior or senior in high school. And when I realized that it did, that people were studying these things, were saying, well, no, if you lift this way, or if you run this way, then this will make you faster, or allow you to run longer, or lift more weights. And we've done this study, and this proves that. That was interesting to me. Again, it was kind of the melding of both worlds for me, the mathematical, scientific, analytical side that I enjoyed and was very good at, but also the sports piece, which again I also enjoyed. So the fact that you could put those two things together and make money at it, make a career out of it, was kind of a perfect storm for me. And so that's initially how I got into the field of exercise science and research in particular. I wanted to be involved in those people saying this is how you should train, or this is how you recover from an injury to get better and faster and stronger. I think physics is very powerful, applying physics into the research that I do, and then eventually into the clinical field. If you have set up your experiment well, and you have good equipment, and you get results from the question you're trying to ask and answer, you can take those numbers to a clinician and say, no, this person improved by this much, and here's the data to show that. And that's powerful. A clinician can't come back and say, well, I really feel that this works better. Well, but the data doesn't show that. And so that's where I think physics is most powerful, is that you can use that quantitative aspect to really support your hypothesis in answering your question.